Welcome back to Oral Surgery Board Review. Today we're going to be talking about our next topic, which is the temporomandibular joint, or the TMJ. We'll start off with some important anatomy. The joint is known as a gangliomo-arthrital joint. That's a fancy way of saying it has two movements. It has both a rotation component and a translation component. Gangliomo means to hinge or to rotate, and arthrital means to slide or to translate. And if you look at this picture, you'll see our joint is unique in this respect because it does both of these movements. So every time we open and close our mouth, it's both hinging or rotating, and it's also sliding or translating. So the first 20 millimeters of opening is due to this rotation. This rotation is primarily due to gravity, although the lateral pterygoids have a small component to it, and it occurs in the lower compartment. So if you look in this picture, it rotates backwards, and that's occurring in this lower compartment. Lower compartment meaning between the disc and the condylar head. Then the next 30 millimeters of opening, that is due to the pull of the lateral pterygoids. The pterygoids attach into the condylar head and they literally pull it forward. So the condylar head starts over here in the glenoid fossa and it slides forward till you get to the articular eminence. That's responsible for the next 30 millimeters of opening, and that occurs in the upper compartment. Some other important anatomy: you have the joint capsule. The capsule is a ligament. It surrounds the joint entirely, and within this ligament you have a synovial membrane. This synovium is responsible for both the nutrition and the lubrication of the joint. Within the joint you have an articular disc. This disc is composed of fibrocartilage. It is avascular and non-innervated. So again, I once saw this as a question. The disc itself is avascular and non-innervated. It is cellular. The fibrocartilage cells derive all their nutrition via osmosis or diffusion because they are avascular. Now, in terms of the vascular supply to the TMJ, the following list is in order of importance. So the first one is the primary source. So the vascular supply to the TMJ is the superficial temporal artery. And if you can imagine, the superficial temporal artery is just the terminal branch of the external carotid. The external carotid comes up and then it just leads straight without turning anywhere is the superficial temporal. If it makes a right turn, that would be the maxillary. And then one of the branches of the maxillary is the mesenteric, which feeds the same named muscle. In terms of nerve supply to the TMJ, the primary nerve is the auriculotemporal nerve. That provides sensation to your earlobe and to your lateral face. And then again, minor contributory from the mesenteric and the deep temporal nerves. Now let's talk about some dysfunctions and disorders. Well, first, we'll start with myofascial pain. As you can tell from the name, myofascial, we're talking about something that's muscular in component, and it is a non-articular TMJ disorder. So it doesn't involve the joint itself, it just involves the muscles of mastication. Now, the more you use it, the worse it will be. So it worsens with function, and it will eventually lead to a decreased range in motion, meaning you won't be able to open. Normally we say MIO, maximum size of opening, should be decreased. Normal should be somewhere around 45 millimeters, so under that would be a diminished MIO. Different etiologies can be responsible for myofascial pain, including parafunctional habits like bruxism, nail biting, clenching, and gum chewing. Also, life stressors can be involved. Certain malocclusions, if it's severe enough, can also indirectly cause extra muscle strain, including a pertinathia, that's a fancy way of saying open bite, or an overjet. So both of those malocclusions, when they're greater than 6 millimeters, and then this final category, a lack of posterior dentition. If you only have premolar to premolar and you're missing your molars, that will also cause extra strain on the muscles, or certain malocclusions, like we said, a pertinathia and overjet. Symptoms of myofascial pain include a dull and diffuse pain, and when you ask the patients to point, they typically point to the muscles as opposed to the joints. You can also use trigger point injections both for treatment and for diagnosis. Different treatment include NSAIDs, splint, soft diet, muscle relaxants, occlusal equilibration, trigger point injections. That means you basically ask the patient where it hurts, you inject lidocaine, and if it improves, then that both functions for diagnosis and for treatment. Increasing the posterior dentition, so via implants or RPD or what have you, not just helping to take off some of the occlusal pressure off of all the anterior teeth, and physical therapy, stretching. All right, moving on to the next category, we have degenerative joint disease. Here we're talking about arthritis. We're talking about arthritic changes that result in the degradation of both the cartilage and remodeling of the bone. Within this category, we have two subcategories: inflammatory arthritis. And when we say inflammatory, we're talking about something acute and inflammatory. So think of things like rheumatoid arthritis, psoriatic arthritis, gout, pseudogout, or ankylosing spondylitis. In all those cases, you have acute inflammation that causes destruction of the joint. And then our second category would be non-inflammatory. And I don't love that term. I'm only using it because you'll see it elsewhere in the literature. But I like to think of this more as a chronic inflammatory, and think of things like osteoarthritis. In osteoarthritis, the hypothesis, the theory as to the mechanism generally has to do with an imbalance between catabolic and anabolic processes. Right, so we know our body is constantly in a homeostasis between those two, and when you have osteoarthritis, you have this imbalance. So you have more catabolism more than anabolism. It just favors it, so you get an increase. You get an upregulation of the following cytokines: TNF alpha, IL-1, IL-6, and those three cytokines are catabolic. So they increase the activity of collagenases and proteases, which will eventually lead to degradation of the joint. But again, this is chronic and slow, and it will generally affect it takes time, versus the inflammatory. Think of it more as something like that's acute and it's autoimmune, and it can even happen in like a juvenile, a young patient. And then our final category would be internal derangement. So this is different from arthritic because you don't necessarily see any arthritic changes or any destruction of the joint, but in internal derangement, we're referring to the abnormal positioning. So the disc is in the wrong position as it relates to the condyle and the fossa, and typically we mean it's anteriorly displaced. So wherever the disc normally should be, it's just too far forward. And in the early stage, it's purely just internal derangement. It's just a positioning thing. But as you get to a later and later stage of internal derangement, it could be accompanied with arthritic changes. So one more time, a nice treat just to help visualize everything that we said. Within the broad category of TMJD, you have myofascial pain, muscular, and then everything else is articular, degenerative joint disease. Within the category of degenerative joint disease, we subdivide that into arthritis. And arthritis, think of itis, think of inflammation, think of destruction, and then we subdivide that further to acute, think of things like rheumatoid arthritis, versus chronic, think of things like osteoarthritis. And then the last category is internal derangement, which is not necessarily destruction, just arrangement, the positioning of the disc in relation to the condyle and the fossa. Etiologies include trauma, joint laxicity, parafunctional habits, altered lubrication, and disc adhesions. Symptoms include decreased MIO, deviation, deflection, palpable clicks, crepitus, and pain. When we say something is internal derangement, like I said before, we're saying it's anteriorly displaced. And then anteriorly displaced, you may have heard the term, it's either with or without reduction. So what do we mean by that? So here's a nice picture. Let's start with the picture on the left. Over here, this is with reduction. So follow the picture as the patient opens and closes. The yellow is the disc. So as you can see, the disc is a little bit too far forward. It should be right in between the condylar head and the glenoid fossa, kind of where the blue tissue is. The blue tissue in this picture is the retrodiscal tissue. And you can see the retrodiscal tissue is stretched forward and the disc is a bit too far forward. But it reduces. So that means as the patient opens, and in their final opening position where they're over the eminence, in that final position, the disc is actually in the proper position. So it's anteriorly displaced, but it reduces. When we use the term reduces, we're kind of using it like when we talk about fractures. Reducing a fracture means to return to its normal position. So here it is reducing. And that reduction will accompany an audible click. In fact, that's what the click is. When you hear the clicking, it's the disc popping into the right place. It's the condyle getting over the disc, and at first it's bumping into the disc, then it eventually gets over it, and it's now between the disc where it should properly be. And then in the picture over here on the right, this is anterior displacement without reduction. And if you look over here, the disc is too far forward to start, and it stays too far forward the entire time. And if you also look at the amount of opening, it's diminished. Right, this patient cannot open nearly as much because as the condyle attempts to slide and translate forward, it actually bumps into the disc, and the disc is blocking it from translating any further. So that obviously will cause a tremendous amount of pain, but not only that, it will prevent the patient from achieving a maximal opening. So that's what we mean. Hopefully these two illustrations really present it nicely. When we say internal derangement, we're talking about anterior displacement, and then we have the categories of with and without reduction. With reduction means that you'll hear the click, but it will get to its final normal position, and without reduction you won't have a click, and you probably won't even be able to open fully because you'll basically be blocked out. Wilks came up with 5 different stages of internal derangement, and we're going to go through them because it's very high yield. So we'll go through it one at a time. Stage 1 is early. It's painless clicking. So it's painless, so completely asymptomatic. And a fair bit of the population would be categorized as a Wilks stage 1 because they have a clicking. And by nature, if you have clicking, then what do we know? We know that the disc is slightly forward, but it reduces. So this patient is completely asymptomatic, normal disc. So you wouldn't expect any of the anatomy to be messed up. And they're having no symptoms. So that would be the earliest stage of stage 1. Once you get to a stage 2, you also have clicking. So what do we know about clicking? Anytime you have clicking, it's reducing. So both 1 and 2, I put them together in the sense they both have clicking and they both reduce. The only difference is stage 1 is painless and stage 2 is occasionally painful. So stage 2, think of something where most of the time it's fine, but occasionally you tell them that their joint hurts. In this case, you will see a thickened disc. That's the only thing that you'll see clinically. Moving on to stage 3. Stage 3, 4, and 5, all these are non-reducing. So you will not hear any clicking at this point, but you will get restricted motion, as you can imagine. So stage 3 is a non-reducing and restricted motion, but at this point you do not have any bony changes. That's what separates stage 3 from all the subsequent stages. The disc is deformed, just like in stage 2, you start to see some changes of the disc. It was thickened. In stage 3, the disc is deformed, it's displaced, but you don't have any bony changes. By the time you get to stage 4, that's the first time where you first see degenerative remodeling of the bony surface and osteophytes. So over here, once you get to stage 4 of internal derangement, it is accompanied with arthritic changes of the joint. And finally, stage 5 also has bony changes, but what separates stage 5 from stage 4 is it has the articular disc itself has a perforation through it. So one more time, just to make everything really clear, stage 1 is painless. Stage 2 is occasionally painful, but again, both 1 and 2 are clicking and reducing. Stages 3 has no bony changes, but it's the first one that's not reducing. Stage 4 also non-reducing, and it has bony changes. And stage 5 has articular disc perforation. Moving on to hypomobility, and by this we mean trismus. The patient has an inability to open. And there's various, within the category of hypomobility of the joint, are things like ankylosis. Ankylosis means there's a fusion, could be a bony or a fibrous fusion of the condyle to the glenoid fossa, and that leads to a hypomobility or a trismus. There also could be fibrosis of the muscle, and there could be this third entity of myositis ossificans, which basically means remodeling of the muscle into bone. So you get little bony islands within the muscle, and that's rare, but there are case reports of that. Generally it's because of trauma and bleeding within the muscle, leading that to this myositis ossificans, where you get bony islands within the muscle. Different classifications. So Topazian came up with a pretty easy one. I don't think this is very high yield. We'll just say it quickly. Stage 1 would be condyle only. Stage 2 is condyle and sigmoid. And stage 3 is everything, condyle, sigmoid, and coronoid. So basically it's just the extent of the ankylosis. The KABAN protocol. So Lenny KABAN has this famous protocol. How do you treat patients? Primarily I say kids, because what you'll see in a second, this really works for kids more than it works for adults. But how do you treat patients with ankylosis? So step 1, you resect the ankylotic mass. Now again, his KABAN protocol is all really intuitive, so we're going to go through it quickly, but everything you could have imagined, this is probably what you would have guessed if you didn't know the protocol. So step 1 is you resect the ankylotic mass. Step 2, you do a coronoidectomy, because that will also help release the trismus. And step 3, you do a contralateral coronoidectomy if your MIO is not more than 35. So if your MIO is fine after steps 1 and 2, then step 3 you just skip. You just resect the ankylotic mass and you do a coronoidectomy on the side of trismus. If that doesn't help you give enough of an MIO, then you'll do a contralateral coronoidectomy. Steps 4, 5, 6, and 7 all have to do with the reconstruction. So now that the mass is gone, the ankylosis is released, now you got to think about reconstructing it. So if the disc is intact, you just replace the disc. If the disc is not intact, then you need a temporalis flap. You need something to interpose where the disc used to be. So you do a temporalis flap where basically you rotate the temporalis down. And then in terms of reconstructive options, for kids you're thinking of things like distraction osteogenesis or a costochondral graft. In part 2 we're going to talk a little bit more detail about what those involve. And then very key, step 6 is early mobilization, and 7 physiotherapy. And that's the KABAN protocol for how to treat patients with trismus. Fibrous ankylosis. So now you're thinking of adhesions. So the primary treatment for that would be an arthrocentesis or an arthroplasty, and via both of them you can, via this endoscope, you could break up these adhesions, lysis of adhesions, or you could do an open surgery like arthroplasty, and you could do a discectomy and remove the disc. How do you prevent re-ankylosis? This is important. One of the concerns is you've now treated you've resected this ankylotic mass. What are the chances that ankylosis will recur? So there's different ways to try to prevent that. One of them, I actually don't have it listed here, is that you do some kind of fat graft to prevent heterotopic bone formation. The other two things I do mention here would be very low dosage of radiation therapy, so about 10 gray weekly, daily for about 2 weeks. Or you could use indomethacin, which has also been shown to be equally as effective as radiation, 75 milligrams for 6 weeks. Costochondral graft. We're gonna get into some of this more. We're gonna get to some of this in the part 2, but let's just go through it quickly now. So costochondral graft is really great for children, and the reason for that is because the rib has a growth potential. And that growth potential means that when you reconstruct this condyle, it has the potential, if everything goes perfectly, to grow with the child, so he doesn't need a secondary surgery. It's most commonly harvested from rib number 6, although it could be taken 4, 5, or 6. And 6 is recommended because it has the best scar. It's hidden within the crease of the inframammary crease. There's some discussion whether you should take a contralateral rib because it has a better angle to it, or do you want to take the right rib because post-op you won't be confused with cardiogenic pain. So both of them are appropriate. Just be aware of the discussion, the pros and cons of which side you want to take from. And then this is a very important point. When you are harvesting the rib, you want to make sure the cartilaginous cap that comes with it is no more than 3 millimeters. And that's important because that will prevent overgrowth. And when the costochondral graft works well, it works beautifully. So here's a nice picture. You'll see they resected a mass in a child, reconstructed it with a rib, and then 8 months later, a whole neocondyle and neocoronoid and neosigmoid, everything grew from that growth potential. So when it works beautifully. And like I said before, make sure that the cartilaginous cap is no more than 3 millimeters. You have to trim it down. And the reason for that is because the cartilaginous cap is the growth center, and studies have shown that when you leave on too large of a cartilaginous cap, you can get overgrowth. So like this picture, imagine just this would keep growing and growing and growing. You get overgrowth, and then you get a posterior, ipsilateral posterior open bite from the overgrowth of this condylar hyperplasia situation. And now you have to do a secondary surgery. Some of the complications from costochondral graft. So in case you ever get asked, what do you do if the cap falls off? The cartilaginous cap separates from the harvested rib. So you have two options. You can either just try to suture it together, or some people say no, at that point it's already too late. You have to start again, get a new graft. Anytime you have a failure and you have to get a new graft, one key point, you don't want to use 2 adjacent ribs. Like if you use number 6, go to number 4 next time. You don't want to use 5 and 6. Because if you take out 2 adjacent ribs, you can get a flail chest. Other complications include pneumothorax. Pneumothorax means air trapping within the pleural space. So here you're going to get labored. Some of the symptoms include labored breathing, tachypnea, hyperresonance, so it sounds like air, a JVD, neck distension, diminished breath sounds, and then you get a chest x-ray. You could also obviously get a CT, which would be the most accurate, but on a chest x-ray, your goal is to try to approximate how big is the pneumothorax. If it's 10% or smaller, you can just monitor it. If the patient has like a 30% pneumothorax, this is a very crude measurement, This is a rule of thumb. If you see a 2.5 centimeter margin, that's approximately 30% of the lung is down. And if you have complete collapse of the lung, then that's 100%. So like I said, a CT, you can get an exact number of how much of the lung is down. On a chest x-ray, there are fancy measurements to try to figure it out. But the crude number to know is that if your margin is 2.5 centimeters, that's about 30% of the lung is collapsed. How do you treat pneumothorax? So again, if it's 100%, you're going to rush to needle decompression. In that situation, the lung is fully down and the patient is having labored breathing and they're having a hard time maintaining an O2 set. Obviously, the first step is always put oxygen on. And then the next step would be a needle decompression. Here, you're taking a needle and you're putting it into the second intercostal space in the mid-clavicular line. So right in the middle of the clavicle, two ribs down, you're going to just puncture and you're going to get a rush of air, and immediately once you relieve that pneumothorax, the patient should have improvement of their symptoms. And then if you have a little bit more time, if you're not dealing with the situation where it's a true emergency, you have a little bit more time, the step would be a chest tube or a tube thoracostomy. Here you make a 2 to 3 centimeter incision. You make an incision horizontally in the 5th intercostal space. And here you're doing it either the mid-axillary line or the anterior axillary line, so as this green dot demonstrates in the picture. One important point, when you go in this 5th intercostal space, you have a choice between should you hug the bottom of the 5th rib or should you hug the top of the 6th rib. The answer is you want to hug the top of the 6th rib, and the reason for that is underneath each rib is a neurovascular bundle. So when you're in the 5th intercostal space, you actually want to be hugging the top of the 6th rib. Some next category, we're going to talk about dislocation or hypermobility. So now patients who dislocate, the joint comes too far forward. That's a subluxation of the condylar head where it comes anterior to the eminence. So it's supposed to go to the eminence, but if it goes beyond the eminence, well then the patient will have this open lock. And then the only way to help them is to push down and back. And I'm sure you guys have all had that experience where these patients come to the OR, the ER, and you reduce them manually. Different etiologies can be responsible, including excessive yawning or opening. Right, it's been reported patients opened too long for a dental procedure, and then they found themselves in an open lock. That's happened to me actually a couple times, and so does that mean I'm taking too long? I guess I gotta work on my speed, but it's important to know how to reduce them. Seizures, tardive dyskinesia, antipsychotics go with the tardive. A lot of the first generation antipsychotics cause orofacial tics, and then last, of course, connective tissue disorders, things like Ehlers-Danlos and Marfan's. They have hyperelasticity of their joints. So how do you treat it? Like we said, manually reduce it, and then you want to prevent it from reoccurring, because once the ligaments and everything is stretched, the propensity to go back into open lock is increased. So you want to prevent that at least in the immediate post-op period. So you can wrap them with a Barton's bandage or an ACE wrap or something to prevent them from opening too much. And you tell them to put prevent excessive yawning, and you tell them to not open too much. What happens if they chronically and just keep repeatedly dislocate? So you can put them in an MMF, that's one option, or you can inject PRP or Botox. You can inject Botox, it's two separate things. You can inject PRP into the joint, and the theory there is anytime you have blood on the joint, you induce trismus. So that's one way of trying to help induce trismus and prevent subluxation. The other option is you inject Botox in the lateral pterygoids. The lateral pterygoids is responsible for opening. Now, that's easier said than done, because injecting the lateral pterygoids is actually quite difficult. We do Botox all the time into the masseter and the temporalis, but when you get to the lateral pterygoids, it's recommended to use an EMG. And then the other options you have are eminectomy. Here you reduce the eminence. Now, when you reduce the eminence, just so we understand, the goal there is not to prevent subluxation, but it's that we know the patient will subluxate, but at least they'll be able to reduce themselves. If you take down the eminence, then they'll be able just to reduce themselves quite easily. And then lastly, there is a fancy procedure. It's gotten out of favor, but it's quite interesting to just discuss. In theory, it's the Leclerc or Daughtry procedure. And here, what you're doing is you're basically fracturing the zygomatic arch inward to block the path of your condylar head. So here's a nice picture of it. And as you can see, the zygomatic arch was fractured intentionally, And this basically is to replicate a ZMC fracture. I'm sure you guys are familiar with ZMC fractures. One of the things you evaluate the patient for is trismus. And sometimes if the arch is displaced enough, it will be in the path of the condyle and it will prevent opening and translation forward. And that's exactly what this procedure intended to do. It intends to intentionally fracture and displace the arch into the pathway of the condyle, preventing a full opening. Moving on to arthrocentesis. So that the goal of arthrocentesis is to irrigate out the joint. Usually we use things like lactated ringers, at least 100 cc's or so, although at least 100 cc's, more than that, great. And you want to get a good flow, and you want to have two little stab incisions, so you have an entry and an exit port. And identifying those two parts, we have the HH line, the Homeland-Helsing line. It's an important line to be familiar with. This, you start with the mid-tragus all the way to the lateral canthus, and you measure 10 millimeters ahead and 2 millimeters down, and that becomes your entry point. That is the site, the top of the glenoid fossa. So that will be your entry. You're going to go into that first line, 10 and 2, and you're going to inject some local. And how much local can you inject? Probably about 2 millimeters. 2 cc's of local should be able to go into the joint, and then you should be able, the plunger, you'll feel a stop, you'll feel like a kickback, you'll feel a bounce, and then you've insufflated the superior component of the joint sufficiently, and that also confirms that you're in the joint. And then your exit port will be 20 and 10. So along the same line, so 10 forward, 2 down is your first point, and then 20 forward, 10 down is your exit. And that should be somewhere around the eminence. So that will be your exit point. The goal of an arthrocentesis is to break up adhesions and to irrigate out inflammatory meaters. In terms of disc repositioning surgeries, so here, as you can see in this picture, you can either placate the disc itself with the suture, or you can use this Mytec anchor, which is a fancy anchor that goes right into the bone, and it basically just secures the disc in the posterior position so it will not be displaced anteriorly. In terms of the procedure itself, in my part 2, we're going to go through this a little bit more detail. I'm just going to mention this. It's important to be familiar with the layers. The most superficial fascia layer, you're going to see the temporoparietal fascia. Then below that, you'll see this auriculus muscle. Then below that, you'll see the temporalis fascia. The temporalis fascia actually has a superficial and a deep component, and it surrounds the temporalis muscle. One important number to be familiar with, the temporal branch of the facial nerve, it will cross the arch anterior to the bony external auditory meatus somewhere between 8 and 35 millimeters. On average 20 millimeters, but we don't necessarily care about the average or the most extreme. We care about the minimum. So based on that study, this is the Al-Kayat-Bramley study. It's very important to be familiar with, and we talk about this in our Oral Surgery Journal Club, a little plug over there. Check it out if you guys want to see the whole study. But at minimum 8 millimeters anterior to the external auditory meatus, where the arch is, that's where you'll see the temporal branch of the facial nerve cross the arch. Anyway, so it'd be important to be familiar with all the anatomy. Eventually you get down to the lateral capsule. You're gonna cut through the capsule, you're gonna find the disc, and then you're gonna placate the disc like we said, or use a Mytec suture. Here's the picture of what I was trying to describe. You measure from the bony external auditory meatus 8 millimeters forward along the arch, and this is where the temporal branch rises up. So as long as you're within 8 millimeters, your incision, when you do your preauricular incision or you do your endoral incision and you hug the external auditory meatus, although you don't want to go into the ear, obviously, but you don't want to go too far forward. So you want to be within those 8 millimeters of safety, and then you should not hit the temporal branch of the facial nerve. Some complications that have to do with all TMJ surgeries in general. So you can get otitis externa, which means an infection of the outer ear. And I'm just going to high yields for this. Just the fluoroquinolones are the treatment of choice because you're trying to cover for pseudomonas, which is the most common antibiotic for swimmer's ear or otitis externa. Anytime you get otitis media, that we're talking about the inner ear, you're going to see a bulging tympanic membrane. Unless, of course, it's already perforated. In that case, you're going to see exudate, and you're going to treat that with amoxicillin, or you can also, and if this recurs multiple times, you can do myringotomy tubes. So a myringotomy tube is basically a tube that will penetrate the tympanic membrane and allow for egress of the purulence. One feared complication would be violation of the middle cranial fossa. Now, if that occurs, you can get a CSF leak. So we're going to digress for a second and just talk about CSF leak. And it's important to note that this bone right here, this glenoid fossa bone, on average is only 1 millimeter in thickness. I know this picture says 2 millimeters. That's the one I found on the internet. But on average, the thickness of bone is 1 millimeter. I think it's 0.97 or something like that. It's 1 millimeter thickness. So you have to appreciate that even with like your needle, you could penetrate through the glenoid fossa into the middle cranial fossa. So let's digress a little bit, talk a little bit about CSF leaks, because this is an important topic. It's also relevant to trauma. When we get to trauma later, maybe we'll talk about it a second time, but let's just know the basics. So what is the CSF responsible for? It's a cushion and a lubricant for the brain. So it provides buoyancy of the brain, so every single time you move and turn your head, you don't have any brain damage. The CSF, because the brain doesn't have any lymphatics, is also involved with removing cerebral waste. In order to get a CSF leak, by nature, you have to have a compromise in the integrity of the dura. Typically, it's accompanied with a fracture. Patients will have rhinorrhea or otorrhea. You'll have discharge. Now, the normal CSF volume is somewhere between 50 and 100 ml. So just take the middle of that for easy numbers. Say most patients have about 100 cc's. The chloride plexus makes the CSF, and you make about 20 ml every hour. Therefore, every single day, your body will keep renewing your CSF volume 4 or 5 times every day, and then it's just absorbed. So it goes from the lateral ventricle to the third ventricle to the fourth ventricle, and then it's absorbed. And your body's continuously making CSF. Now, your normal CSF pressure should be somewhere around 10 millimeters of mercury. And that will be equal to your ICP, your intracranial pressure. And the causes of CSF are either traumatic or non-traumatic, and within traumatic it could be accidental or iatrogenic. Like if we're talking about arthrocentesis or arthroscopy, well then chances are that's something that you caused. How do you diagnose it? So this is important. There are 3 famous tests that are discussed. The first is the halo test. So you basically take some of the secretions, the otorrhea, the rhinorrhea, and you put it on a filter paper. And because of the different rates of diffusion, you will see that the CSF forms this outer ring, whereas the serum or the blood stays in the middle. Then that forms this halo in this picture. Now, it's not a very specific test, but it's important for us to be familiar with. It's probably the easiest test and the quickest test to do. And then you could do more specific tests, include like lab tests, and that would be a glucose test. So we know CSF should have a glucose concentration of at least half the serum, if not more. So whatever your serum is, your CSF should have at least half the glucose concentration, and that's as opposed to a nasal secretions like snot that has almost none, very minimal amounts of glucose, 10 mg or less. So that's one way of doing it. But it's not 100% specific, but it is very quick. The most specific, the most sensitive test is the beta-2 transferrin test, because beta-2 transferrin, it's a glycoprotein that is only found in CSF. So that will tell you without a doubt, like 95% sensitivity, that will tell you very clearly whether you have a CSF leak. The only problem is it takes several days to do and requires a special lab. Important imaging to talk about. So obviously, if this is in the context of a fracture, then usually you don't need to do the radioiodine contrast, but anytime you have a fracture, you assume that's the site of your CSF leak. But if you can't find it and you want to pinpoint exactly where your CSF leak is, you could do an intrathecal injection, which means you're injecting kind of like an epidural, but instead of going to the epidural space, you're going to the spinal canal, and you're injecting iodine radiocontrast. And then you obtain a CT, and you'll be able to see exactly where your CSF leak is. Of course, it's important to mention, if your CSF leak isn't active, then it will be negative. But of course, if it's negative, then that's probably good news. How do you treat CSF leaks? So for the most part, they self-resolve, and you don't have to do much. So you tell the patient, elevate the head of bed, strict bed rest, avoid any of these Valsalva maneuvers that would increase the ICP, avoid coughing, avoid nose blowing, sneezing, and straining. No lifting weights, obviously, right? Just strict bed rest. And the goal there is you decrease the ICP, you decrease the intracranial pressure, and just allow the CSF leak to close on its own. You could also use medical acetazolamide, which should decrease the ICP. And there's some discussion whether or not you place the patient on antibiotics. The feared complication of a CSF leak would be meningitis, which could be fatal. And There are some people who do recommend, so I say plus or minus, because really just I would defer to neuro at that point. From our standpoint, just be aware of the conversation, be aware of the risk of meningitis, but whether or not we use antibiotics, we defer to neuro. So like I said before, most of them self-resolve. If there's a fracture involved, then by reducing the fracture, that will help the CSF close. If the CSF does not close after about a week, at that point you consider a lumbar drain. A lumbar drain, the goal there, it's not going to directly close the CSF leak, but what it will do is it will further reduce the CSF pressure. And if the CSF pressure is so low, right, imagine if you have a high flow leak versus a low flow leak. A high flow leak is not going to just close on its own, but if you could do a lumbar drain and lower the CSF pressure so low so that give the body a chance to close. And then if not all that fails, then at that point you're looking at direct repair. And there are different endoscopic ways of doing it, and you can also just do open surgery. Wherever you have the CSF perforation, you have to do some kind of interpositional graft. You could use fat or you could use bone to try to plug the leak. Other complications, so we're done with CSF. Moving on to other things. So we talked about the important anatomy. We know the temporal branch of the facial nerve is in the vicinity of the TMJ, and you could be injured. If it does happen, most of the time it's temporary, right? If you're just doing arthrocentesis or something, chances are you stretch the nerve and you're having some temporary paresthesia, paresis. Right now we're talking about a motor nerve, and that causes muscle weakness. So you're talking about paresis. But if it tends to be permanent, at that point, the most important thing is you're going to ask the patient, can they open and close their eye? If they cannot close their eye, then you're going to be concerned about the eye drying out. So you're going to offer the patient drops and lubrication, and you're going to tape the eyes at night so it doesn't overly dry out. And then you could consider, again, this is really only for permanent patients, and I would wait a few months to see if this resolves on its own. But if it doesn't, at that point you're considering gold weight implants, where they put these implants in the upper eyelid to help weigh it down so the patient can close. Again, super rare. I know for patients that have, like, sometimes we do when it comes to the realm of cancer, there are times where we will sacrifice the facial nerve, but it's very rare from like a TMJ surgery to have permanent facial nerve paralysis. Another complication to be familiar with, Frey's syndrome, which is auriculotemporal nerve syndrome. This is basically, it's an interesting syndrome. You get gustatory sweating and flushing. Here's a nice picture that shows. So basically, when patients are eating, somehow some aberrant innervation is stimulating their sweat glands, and they get flushing and sweating right over their parotid gland. And what happens is, anytime you do surgery near the parotid and you disrupt the neurons, you disrupt all the axons going in and out of the parotid, which we know is where the facial nerve travels through. And then in the process of healing, some aberrant re-innervation occurs, and the parasympathetics from the parotid innervate the sweat glands. And every single time the patients chew and masticate, that releases acetylcholine, and that triggers the sweat glands to activate. The good news is most of the time it self-resolves, but it is interesting to know just the mechanism and how it works. And there are different short, easy, quick ways to fix it. And then, so the most common, Botox, I wrote this third, but this is not in order. Botox is the gold standard, but also important to know you can use scopolamine, which is an anticholinergic, or glycopyrrolate, or Botox. And Botox generally, even though we know Botox doesn't last more than like 4 or 5 months, we know that Botox is very effective, and rare that patients, and because I said it usually self-resolves, rare that patients need more than 1 dose of Botox. Moving on to bleeding. So there's 3 important arteries in the vicinity of the TMJ to be familiar with. The most important is the IMAX. So the internal maxillary artery. The internal maxillary artery is a branch off the external carotid. So follow my mouse, external carotid comes up. Like I said before, superficial temporal is just the terminal branch going straight. The IMAX is what turns inwards. And here's an important number to know. It's 20 millimeters from the condylar head. So from condylar head down to the IMAX is about 20 millimeters. That's obviously very important, because anytime we do a condylectomy or a TMJ replacement, we're going to be cutting off the condyle, and you could be concerned about cutting through the IMAX. And in fact, some people are so concerned that they'll send the patient to IR pre-surgery to have the artery coiled. The other way of dealing with it is that you cut the condyle off in segments. So instead of removing all 20 millimeters in one cut, you cut about here, and then you cut another, then you push up on the ramus upwards and you cut the second cut. And by doing that, that also helps avoid risk of damaging to the imax. So 20 millimeters below the condylar head, that's one important number, and 3 millimeters medial to the sigmoid notch. And as you could appreciate, it's just on the other side of the sigmoid notch. A second most important artery to be familiar with is the masseteric. The masseteric, as you can see in this picture right here, dropping down, this feeds the masseter muscle. And last but not least is the middle meningeal artery, as you can see in this picture, going right up into the middle meningeal. This supplies all the brain. So the middle meningeal artery, important numbers to know, it's 30 millimeters medial to the arch. So it's quite medial, but it's only 3 millimeters anterior to the glenoid fossa. And here's one more picture so you can appreciate it. Here's the imax coming down, and then here's the middle meningeal going up. And all right, we're basically done with the talk. This is part one. Part two, we're going to talk about TMJ replacement and prosthetics, including Biomet, which is a stock, versus TMJ Concepts, which is a custom. And that's it for today. And in part two, we'll talk a little bit more about the surgery, including prosthetics and all of the approaches, the incisions, and the important anatomy related to that. And I'll see you guys shortly.